Hi everyone, my name is Janet Guelphy and I'm doing this infectious disease PowerPoint on MRSA. Here is a little history of MRSA. MRSA started off as Staphylococcus as it was treated originally with penicillin, and then in the 1950s it became resistant to both penicillin and methicillin and became MRSA as we know it today. There are three groups of populations that are able to contract this virus, one mainly being hospital patients, two being recent hospitalizations now in outpatient care settings, and three, any persons in the community. MRSA spread from skin-to-skin contact or touching contaminated surfaces. Risk factors include surgical wounds, IV sites, prolonged hospitalizations, prolonged antibiotic use, immunosuppressed patients, hemodialysis, or patients in the community having tattoos or body piercings. The Infectious Disease Society of America posts evidence-based practice guidelines for patients with MRSA. They also post these guidelines for healthcare providers caring for these infected patients. They discuss the management of MRSA in different locations, including skin and soft tissue infections, bacteria and endocarditis, pneumonia, bone and joint infections, and central nervous system infections. These guidelines recommend medication dosing, monitoring, and management based on the site of infection, age, and drug sensitivity to the pathogen. The Infectious Disease Society of America posts medication treatment of MRSA based on the site of infection. To start with these skin and soft tissue infections, they recommended vancomycin, Zyvox, Cubicin, Vivitiv, clindamycin, and Teflaro. With the bacteremia and endocarditis, they recommended IV vancomycin and daptomycin. For pneumonia, they recommended IV vancomycin, linezolid, and clindamycin. And then in the pediatric population, they recommended vancomycin. As you can see, vancomycin was a real heavy hitter among all the different sites of infections of MRSA. So I'm going to spend a little more time detailing this medication. To begin, it inhibits cell wall synthesis, promotes bacterial lysis and death, and binds specifically to molecules serving as precursors of cell wall biosynthesis, which is descriptive of vancomycin. It is used for gram-positive and Staph aureus. It is either used parenterally or PO and is reserved for serious infections like MRSA. Because vancomycin is such a strong drug in order to fight off MRSA, it comes with some pretty serious side effects and adverse effects. One of these include red man syndrome, which is an adverse effect that occurs during the transfusion of IV vancomycin and is shown through flushing, rash, itching, tachycardia, and hypotension. Later on down the road, with extended usage, it can cause renal toxicity. And risk of these include dose-related, like a prolonged use of vancomycin, and it's also increased with concurrent use of other nephrotoxic drugs, including aminoglycosides, cyclosporin, and NSAIDs. Vancomycin is contraindicated in high-risk patients. You're supposed to use caution with these patients that also have renal impairment, as it causes renal toxicity. During the course of treatment with vancomycin, there are some things that both the healthcare provider, the nurse, and the patient need to monitor for. These include red man syndrome, which is the infusion reaction, trough serum levels, serum creatinine levels, which with a 50% increase, the dose should be reduced as it is causing renal toxicity. They should both monitor for antimicrobial effects, including reduction in fever, pain, edema, and inflammation. There's education that needs to be provided for the patient, including consulting their healthcare provider if they are taking other nephrotoxic medications, including aminoglycosides, cyclosporin, and NSAIDs. The patient needs to be educated that they should look at all of their over-the-counter medications to see if they contain any form of NSAIDs, including ibuprofen, etc. And they need to take the full course of the medication, as with other antibiotics. In addition to vancomycin, there are 5 other medications that the Infectious Disease Society of America recommends. They either are recommended in combination with vancomycin or they are recommended after vancomycin is tried if vancomycin is not working properly and they're used as second-line drugs. So to begin, the daptomycin has some side effects including constipation, nausea, diarrhea, injection site reactions, headaches, insomnia, rash, and myopathy. They are contraindicated just if there's known hypersensitive reactions to the drug. For the monitoring, they need to monitor the levels of CPK weekly, and they should be discharged if the medicine causes muscle pain or weakness, with in addition to the rise of CPK. Patients need to be educated that they need to complete the entire course of the medication and report any muscle pain or weakness to their healthcare provider, and they will be needing routine lab draws during this course. Now for Zyvox, there are some side effects including diarrhea, nausea, headache, phenylketonuria, myelosuppression, and neuropathy. Patients need to avoid MIOIs for the risk of hypertension crisis or SSRIs for they increase the risk of serotonin syndrome. Monitoring for Zyvox include weekly CBCs and signs and symptoms of neuropathy, including optic and peripheral neuropathy. Patients need to be educated that they are going to need frequent lab draws, and they need to understand the signs and symptoms of neuropathy and myelosuppression. Lastly, on this slide, we have Vibativ, and side effects of this drug include taste disturbance, nausea, vomiting, foamy urine, red man syndrome like vancomycin, prolonged QT intervals. There's a black box warning including the creatinine clearance being less than 50 milliliters per minute will increase mortality. This drug is contraindicated with concurrent use of nephrotoxic drugs and drugs that prolong QT intervals, and is also contraindicated in patients with heart failure. Patients need to be monitored for their creatinine clearance, EKGs, and infusion reactions like the red man syndrome. Patients should be educated on the signs and symptoms of red man syndrome to avoid nephrotoxic drugs including NSAIDs, ACE inhibitors, aminoglycosides, and they are going to need frequent lab and heart monitoring. On this slide, we have the last two drugs recommended by the Infectious Disease Society of America to treat MRSA in combination with vancomycin, or as said before, as second-line treatment. To begin, we have clindamycin, which side effects include C. diff, abdominal pain, fever, and leukocytosis, watery diarrhea, etc. They are contraindicated with a history of pseudomembranous colitis or ulcerative colitis, or if the patient has a history of hypersensitivity reactions to this drug. Patients need to be monitored for signs and symptoms of C. diff, which include 5 watery stools per day, abdominal pain, fever, and leukocytosis. These patients should also be educated on the signs and symptoms of C. diff and to promptly report any of these signs to their healthcare providers so they can get treated for the C. diff. Lastly, we have Teflaro. Some side effects include hypersensitivity reactions, including urticaria, rash, hypotension, difficulty breathing, and anaphylaxis, although this is rare because cephalosporins are generally well tolerated. The only time this is contraindicated is if they have a hypersensitive reaction to this medication or if they've had history of severe reactions to penicillins. Patients should be monitored for hypersensitivity reactions or the indications of any microbial effects, the antimicrobial effects, which include reduction in fever, pain, edema, and inflammation. That just means the drug is working, but there's no frequent lab monitoring with this medication. Patients just need to report any signs and symptoms of hypersensitivity to their healthcare provider, and they'll stop that immediately. Thank you so much for listening to my presentation, and here are my references used throughout the presentation.